Hi, I want to talk about major depression. Major depression. You heard about bipolar, that is depression and mania, but I'm talking about major depression alone right now. Okay, let's go. Before you can make the diagnosis of major depression, you need to rule out schizophrenia. You need to rule out schizoaffective disorder and make sure there is no mania or hypomania. Then you can comfortably label the individual as having major depression after ruling out schizophrenia, schizoaffective disorder, and no mania or hypomania. Epidemiology. The lifetime prevalence is about 12% of everybody on Earth, commoner among ages 15 to 25 years and elderly greater than 65. It is more in females to male at ratio 2 to 1 respectively. When we're talking about causes of depression, the major factor here is genetics. It is inherited, and that will be accounting for about 70% of cases of major depression. The likelihood of you coming down with major depression is twice if any of your first degree relatives have been affected. For example, if your mom, your dad, or your siblings have been diagnosed with major depression, then watch out. You are more at risk. Neurotransmitters have been implicated in the pathogenesis of depression, and they are decreased level of 5-hydroxytryptamine, decreased norepinephrine, decreased dopamine, increased GABA, decreased level of glutamate, increased cytokines, abnormal hypothalamic pituitary adrenal axis activity, certain substances like medications, street drugs, and steroids. Psychological factors here with low self-esteem, aggression towards self and family members, negativity, job loss, bereavement, child abuse, neglect. Comorbidity could be with anxiety, substance abuse, developmental disability, dementia, and eating disorder. What I have tried to put up here is someone with major depression could have major depression with anxiety and be using substances, substance abuse. The individual could have developed with some developmental disability, and the person could even be having dementia or be having eating disorders as well. What are the risk factors here? Gender. It is more in females than males at ratio 2 to 1 respectively. Positive family history is not to your advantage. Childhood experiences like loss of parents early in life is a risk factor. Childhood abuse, if you have been abused as a child, anytime you remember your ordeal in the hand of your abusers, you may likely come down with depression. So being abused as a child is a risk factor. childhood neglect, you were not well cared for as a child, anytime you remember, that might cause depression. Personalities. Those who are insecure or dependent, or those who are obsessional, are likely going to come down with major depression later in life. Recent psychosocial stressors like illness, many that have been diagnosed with chronic disease condition or pain may come down with depression. Financial problems all around the globe, people who are poor may be sad, or they are doing business and anything has crashed, maybe plane crash, shipwreck, fire incident, and so on and so forth. People could become so depressed, commit suicide, and die. Legal issues, when it's too much for you to handle, litigations against you that's likely going to take your freedom and your money, the individual could become depressed. Academic failure and relationships that are not working is very common. Comorbidity, like I've earlier mentioned, like anxiety, substance abuse, developmental disabilities, dementia, and eating disorders could contribute. If you are in a relationship, but relationship is not working, like I've just said, so you have no one to confide in, then the individual is brooding upon the problems in his or her life on a daily basis by him or herself alone, then depression is at the door. Social isolation, not belonging to any religious groups, not pairing up with people, not socializing, always being by him or herself, the individual could come down with depression at any slight reason. Low socioeconomic status, just as like we found in financial issue up there. In elderly, 15% of them may likely come down with depression. Those in group homes, 50% will likely come down with depression. So in the general populace, 15% that are already elders may be having major depression. Why? Those that are in group homes, almost half of them will likely have major depression. When an elderly man or woman is now about 65 years old, they likely come down with depression. And elderly people have increased suicide rates and increased social isolation. It is more in males than females when it comes to suicide. Diagnosis. We have mnemonics: MS, IG, ECA, PS. Mood. When you ask a major depressed individual about their mood, they'll tell you, I'm depressed. There are questionnaires you can give them by the time they submit, then you need to act fast. Sleep is either the sleep is decreased or they sleep more, hypersomnia or insomnia. Interest is now down. They don't have interest in many things anymore. They feel guilty about a particular situation, like I've seen an individual that was involved in a road traffic accident, everyone died except him, and he was going around the rest of his life with that guilt. He didn't kill them, but in fact, he could have died as well. The energy level will be down, and they might find it difficult to concentrate. Anhedonia is lacking interest in what the individual had taken pleasure in the past, like camping, going out with family members and friends. They will tell you, no, I'm not interested this time. Not because they don't have the money, they are just not interested. Psychomotor retardation, and of course, suicidal ideation, parasuicide, and frank suicide. When you are able to pick 5 out of these 9 factors, then you can make the diagnosis of major depression if all those 5 points have occurred in the last 2 weeks. So 5 of all this occurring in the last 2 weeks is enough to make the diagnosis of major depression. When the diagnosis is made, the doctor must indicate if the depression is with anxiety or it is mixed features, melancholic features, atypical, psychotic, catatonic, or postpartum depression, or this is depression that is seasonal, occurring mostly in winter times, and the individual is fine in summer when he or she could jump around. Treatment. First, lifestyle. Increase exercise. Decrease the stress in your life if it is under your control. The other time I said some people believe that low level of zinc and vitamin B6 is responsible. You might increase zinc supplement, some do that, and psychotherapy in form of cognitive behavioral therapy, family therapy, group therapy, or interpersonal therapy. There are a lot of medications for those who are having major depression, and the best among them is selective serotonin reuptake inhibitors. You can also choose from serotonin norepinephrine reuptake inhibitors like Venlafaxine, and the first line is Sertraline, that is Zoloft, Escitalopram, Venlafaxine, and Mirtazapine. You can augment with Bupropion, Quetiapine, Aripiprazole, and Lithium. When we are treating depression, we are mindful of possibility of mania. That's why some will use mood stabilizer along from the beginning. And there is a window of suicide while treating depression, because the depressed individual will be having low energy and psychomotor retardation, particularly in younger age group. When they are on selective serotonin reuptake inhibitors, will be on the watch out for the suicide window when they will suddenly have energy, but then the mood is still depressed, but the energy is up. So that time is risky for them to have ability to carry out parasuicide or frank suicide. So we watch for that. 2 weeks when the patient is on medication before we can start noticing improvement in symptoms. It's not like analgesic that you give and the effect will be not noticed in the next few hours. No, 2 weeks before we start noticing improvement in symptoms. It is going to take 4 weeks before the doctor will say, okay, let me now review what has been going on with you as far as the medications are concerned. So when the symptoms will start abating after 2 weeks, 2 weeks after that, which will make it 4 weeks, the doctor can say that medication is not working enough, whether I will have to increase the dosage or change to another member of the class or change to another class entirely or add another medication from another class to what I'm doing right now. Electroconvulsive therapy will be employed if there's no improvement with the medications we are taking. I did not put tricyclic antidepressant there on the list of medications because we have a lot of good other medications now that using tricyclic antidepressant is not that present. And because of the possible side effects, particularly on the cardiovascular system. So we employ ECT when there's no improvement with these medications or there is severe depression or the treatment is resistant or the patient is having associated psychotic features along with the depression. Phototherapy could be employed if this is seasonal, particularly those who are doing shift work or they have sleep dysregulation. You can employ phototherapy. It is not enough to make the diagnosis, have phototherapy or electroconvulsive therapy or any of the medications done without addressing social life. So vocational rehabilitation will be necessary. There is possibility of radiological intervention with deep brain stimulation and vagus nerve stimulation. Prognosis. 40% will continue to have the symptoms after 1 year of treatment. So you made the diagnosis, the individual is placed on medication, lifestyle changes, psychotherapy and everything. 40% will continue having the symptoms after 1 year. 20% will have decreased symptoms and they will not be able to meet the full criteria for major depression again. That's good news for them. Why? 40% will have no more symptoms and they will no longer have the disorder anymore. So there is no fixed time to stop the usage of the medication, but it's based on these facts that 40% will no longer have symptoms anymore, but because there's possibility of relapse, we don't stop their medication abruptly. We tail off. Then 20% will have decreased symptoms and they will not be able to meet the diagnostic criteria with those 9 different points, and having 5 of them for a good 2 weeks. You are likely not going to find that in them anymore, but they are not completely out. So about 60% will give positive signs that your medication is working, while the remaining 40% will remain the same, and you continue to adjust with the instruction from the psychiatrist. In conclusion, approach your doctor once you are feeling somehow. I mean, once you notice that your mood is depressed, you're not happy, you're not doing what you're supposed to do, you're feeling guilty, you are no longer having interest in what you've been having pleasure in the past, and so on and so forth, please contact your doctor. Depression can lead to suicide, so don't keep it to yourself. I'm wishing all affected people well and making promise right now that as far as medications in depression are concerned, I will make a separate presentation on the different types of medications, the side effects, and how to make appropriate choices depending on different age groups of people that are depressed. Thank you. Be on the lookout.